good afternoon, good evening, and good morning to everyone, depending on where you are. My name is William Wells from the USAID TB team, and I'm delighted to be with all of you today to go through this webinar on assessing the quality of TB services in Nigeria. So before we introduce the presenters, I'd just like to introduce this kind of technically very briefly, just to say, I think most people on this call are aware that the private sector in most high TB burden countries is at least 50% of initial care seeking, and in some countries up to 80%. And so catching people in the private sector as soon as they seek care is really critical. There has been a tendency in the TB community to focus enormously on notifications and increasing TB notifications. It is a marker of, obviously, of diagnosing, picking people up. But if we're not careful in engaging the private sector, if we just focus on TB notifications, we may not actually be changing much of anything of the patient experience. So maybe that patient would have been detected anyway, just not notified, and maybe they would get the same quality and type of care. So the stress in this webinar is on taking that to the next step and saying, okay, if we're going to detect people with TB in the private sector, we need to make sure that the quality of care in the private sector is either good or it's improved over time. And we need surveys like the ones that you're going to hear about today to make sure that that's happening. And only then are we confident that we're actually having patient level impact. So this is a really critical area of work. We can go to the next slide. We're very privileged to have an excellent group of presenters and commenters today. Depending on availability, we'll have either opening or closing remarks from Chukwuma Anyeke, who's the National Coordinator for Nigeria's National TB and Leprosy Control Program, and from Omosolewa Olayaram, who's the Deputy Director of the Office of HIV/AIDS and TB in USAID Nigeria. The main presenters for us today will be Balanle Olasela Faleya, who's the TB Technical Director for the Shops Plus TB program in Nigeria, working with APT Associates. Lauren Rosapep from APT headquarters is the Research Monitoring and Evaluation Lead for the Shops Plus project. And Mariosa Amarekwa is the CEO and Managing Consultant of Caliquant Services Limited, which is a research firm based in Lagos, Nigeria. We'll also have a discussant, Madiko Pai, who's the Associate Director of the McGill International TB Center, and closing remarks from Guy Stallworthy, the Global Lead for TB Private Provider Engagement with the Bill and Melinda Gates Foundation. So we've got a great lineup, and if we can go to the next slide. So this will be the agenda, and I think we will proceed to the presentations because our two introductory speakers, I think, are still traveling, but will hopefully join later. So we can go to the next slide. And Balanle, please get us started. Thank you so much.
Thank you, William, and welcome everyone. We'll start off by discussing the findings from the Ministry Client Phase 1 survey conducted between June and July 2019. And by way of introduction, next slide, please. This survey was conducted by Shops Plus with USAID resources. Shops Plus is sustaining health outcomes through the private sector plus, and we're USAID's flagship initiative in private sector health. The overall objective of the program is to increase TB case detection and treatment through the private sector by establishing a multi-cadre network of private providers. The clinical facilities, that is the hospitals, the nursing homes, constitute the hub that receive referrals from the spokes. And as you can see on the infographic on the right side of the slide, The spokes comprise of the drug shops that we call PNVs in Nigeria, the community pharmacies, and the laboratories that are owned by private individuals. This is the hub and spoke model that we operate in Nigeria. The Shops Plus program has been implemented in 15 states in Nigeria, including the Federal Capital Territory. Next slide. So for the phase 1 survey, we sought to fill 2 major areas of knowledge gaps in TB program in Nigeria. The first is the uncertainty about the quality of TB services being provided in the private sector. Before Shops Plus, most TB programming has been in the public sector, and very little was done in the private sector. So we do not have a lot of information about the quality of care being provided by private providers. We also did not have a lot of information on the operations and the network formation going on and finding those TB cases in the private sector. So what we did was to implement a mystery client survey to assess the quality of TB services in urban areas of Lagos and Kano with USAID funding. Phase 1 was in 2019, while phase 2 was in 2021. We surveyed a sample of private facilities being supported by Shops Plus and a sample also of the public facilities that are owned by government. This webinar focuses on the results from the mystery client survey, both public and private facilities. Next slide, please. Just to talk a bit more about what a mystery client survey is a research methodology that uses trained data collectors to pose as clients to assess the quality of services being provided in facilities. Different cases are presented by the mystery clients, and they examine the responses that the providers give on presentation. It's a valid method, it's rigorous, and it's actually much better because it overcomes the biases associated with observational studies and face-to-face surveys and client exit surveys. The phase 1 survey assessed a total of 269 Shops Plus facilities and 842 public facilities done in 2019, while the phase 2 survey assessed a total of 245 Shops Plus facilities and 131 public facilities, a bit less than the numbers surveyed in 2019. Next slide. We did actually 4 cases in phase 1 and 2 phases in phase 2, but 2 scenarios actually cut across both phases. The first is a textbook case of a presumptive TB who will present to the facilities, to the providers, complaining of cough and fever that is not getting better. What we expect the providers to do as correct management is to screen the patient further by asking more questions, initiate further diagnostic testing, either by collecting sputum samples or by referring for an X-rays, and to avoid prescribing unnecessary medications, including anti-TB drugs. And if the patient is probed further, they were told to admit having weight loss, clear sputum, nice sweat, and not having any previous history of TB, no relatives with TB, or family member that are coughing. For the case 2 scenario, it was a patient who will present with a positive TB result, claiming to have been referred by a pharmacy to that clinical facility for treatment. What we expect our providers to do in both the public and the private sector will be to confirm the diagnosis by actually looking at the result and asking the patient to start treatment immediately and cancel them towards doing that, by telling them more about TB treatment, about how to engage a treatment supporter, and to initiate them on TB treatment. And if asked, the patient, the clients, mystery clients, were trained to identify a family member who would pose as a treatment supporter. Next slide, please. So in phase 1, for the case 1 that we just described, the typical textbook case of presumptive, the client was asked about the duration of cough and access to diagnostics. And what we found was Shops Plus facilities doing much better in at least 2 criteria out of 3 in terms of screening the patient more and providing feedback and being referred for diagnostic tests, either for sputum or for X-rays. We saw the private providers doing less than the public facility in terms of not prescribing unnecessary antibiotics, and this is expected, but private providers are more in it for profits and they are more likely to prescribe medications just to increase their income. Overall, we saw the Shops Plus facilities correctly managing the patient in 35% of the cases compared to 20% in the public sector. I mean, this is the first indication that we have that the quality of service in the private sector is comparable and in some instances better than the quality in the public sector. Next slide. For the case 2 results, where the patient presents with a positive TB test result and want to examine how the provider is able to move the patient towards treatment, we saw short plus providers actually doing better than the public facilities in 4 out of 5 criteria about confirming diagnosis, explaining the disease and the treatment, and also move the patient towards a treatment supporter. Again, they lag behind the public facility in terms of not prescribing unnecessary antibiotics and steroids. And that is expected in line with the business model of private providers. Overall, the short course providers manage patients correctly in 18% of cases, while the public providers did this correctly in 13% of the cases. Next slide. Having done phase 1 successfully, we identified the gaps that were very obvious from phase 1 survey and intervened, put in some measures to correct these gaps before phase 2. We're going to look, the next slide will show us a number of things that happened between phase 1 and phase 2. Next slide, please. So specifically, we strengthened our sputum referral system. We thought that the bottlenecks in sputum collection and transportation and access to diagnosis would be a major issue that could have discouraged providers from collecting samples in the private sector. So we strengthened this system, and we also strengthened availability of diagnostics in the private sector. Got a private facility that has a 60-module machine, and a lot of things became much easier for providers. So this improved significantly. We also developed job aids to aid providers to counsel new patients on TB. We also developed job aids for the patients themselves to give them more information about TB. Both of these tools had a lot of information on TB itself, TB treatment, and how to engage treatment supporters. And of course, COVID-19 happened between phase 1 and phase 2. And we're also eagerly looking forward to finding out how COVID-19 could have impacted the quality of TB services being provided in the public and private sector. We also got a collaborative effort with McGill University in 2020, where we got funded by McGill to implement a multi-country study on the impact of COVID-19 on quality of care in Nigeria. So APT Associate led the Nigeria arm of the study, and the lead investigator for the global study, Dr. Pai, will be discussing at the end of this presentation. And I'm sure we'll have a lot to say about what we found in Nigeria and globally as well. So phase 2 allowed us to assess the effectiveness of our adaptations to COVID-19 and influence of COVID-19, if any, and of course, the effectiveness of interventions we have put in to fill the gaps that we saw in phase 1. I'll hand over the presentation to Mariose, who is the lead for Qualicons, the organization that helped us to implement the, both the phase 1 and the phase 2 surveys in Nigeria. Thank you. Over to you, Mariose.
Thank you, Dr. Bola. Implementing the mystery client survey involved a lot of technical and logistic preparedness. And for us to successfully carry out the mystery client survey in field, we engaged the following activities. First, we had to carry out a facility sample verification. We engaged a team of auditors in Lagos and Kano to verify the facilities that we were presented with by the Shop Plus team. And these were where the data collection was to take place. The verification entailed ensuring that the facilities were currently existing as at the time of visit, the level of accessibility, including landmarks, to make it easier for the mystery clients to access these facilities, and also to confirm the facility operating times. These were necessary to pave way for a natural future visit by the mystery clients. The success of the mystery client surveys also hinged on the type of mystery clients that we engaged. So the recruitment and selection process was very rigorous for us. With the type of data, undercover data collectors for this type of study is critical, like I mentioned, and hence we took great care in recruiting and selecting only those with very good recall abilities, which we assessed through memory tests, and also those with good communication skills amongst other criteria. To ensure these mystery clients feel comfortable in their roles as undercover data collector, we set aside extensive time for training and role plays. For this study, we utilized 4 weeks. We started with health screening, which were real health checks conducted by SHOP Plus medical personnel. This was done to ensure that the mystery clients were physically fit and do not have other health indices that may influence other undesired treatment protocols by the potential health providers they were to visit and interact with in the field. The mystery clients were also provided with scripts, like Dr. Bola mentioned, to align with the desired patient character. Following the individual and group enactment within these mystery clients, mock interviews were conducted by SHOP Plus health providers again to assess the mystery client's performance and level and quality of interaction. We also went over several possible challenges the mystery clients can potentially encounter in fields that may lead to detection, as well as different mitigation strategies. It was also emphasized during training that the mystery clients avoid any form of invasive procedure during interaction, such as blood draws and taking medications. This is just to protect them from harm, and as well, we are following the research ethics. We also conducted adequate training on Survey CTU. This is the digital platform for collecting data during debriefing. That is the exit interviews by the clients after interacting with the providers in the facility. We then proceeded to carry out, classroom role plays, then dry runs in field to test out the mystery clients' real life experiences, or what they've learned, during training and they've practiced with. This was then progressed to piloting, where we tested, in addition to field experience I mentioned, the logistic feasibility of collecting data from multiple facilities by mystery clients in a single day. We were also able to assess potential detection risks during this practice sessions, role plays, and piloting. Following all this, we were well positioned to carry out the data collection. Next slide, please. We encountered several challenges during data collection in phase 1 and 2. However, for the sake of time, I'll quickly highlight the notable ones. So for phase 1, first, we got information from the SHOP Plus network officers that they were recognizing and reporting duplicate patients in their database. This was because the MCs were all going by single names, which was what we practiced with during the training sessions for males and females. The responsibility of network officers were to capture the data of a potential TB case, document and ensure, treatment follow-ups. The network officers were deliberately not informed of the ongoing mystery client study, hence it became a challenge to bypass them. Acknowledging this challenge, we went ahead to develop multiple fictitious names for every single mystery client visit to this facility. Secondly, the providers were insisting on HIV testing. Granted, HIV testing was part of the treatment plan for TB. However, to protect mystery clients, it had been emphasized during training that they cannot engage in any invasive procedure. Hence, we had to continually come up with mitigating strategies to avoid this procedure. Strategies such as, said I just had a recent test in an outreach. My religious facility. I am currently fasting, or I have to discuss this with my spouse before testing. Next slide. So for phase 2, the providers were insisting on verifying treatment supporters or spouses' contact phone numbers on the spot before commencing TB treatment plan, and after a few days for follow-up. This may be as a result or as a backdrop of the results from phase 1, where this was not, the case. And this time the providers were responding based on interventions from phase 1 results. So to mitigate this challenge, we had to set up a working phone line by creating a call center to receive calls from these providers. In phase 2 as well, the providers were more insistent this time that mystery clients take medicines in their presence. Of course, this was also attributed to the outcome from phase 1 results. Again, we had to come up with on-the-go strategies to mitigate this challenge, such that they were currently fasting or may need to get home before taking the drugs, or they had to go home and notify their spouse of the treatment plan before commencing, and many more. The phase 2 data was also collected during the peak of COVID-19 pandemic, This made the providers more critical of the symptoms presented by patients at their facilities, of course. And to ensure that the providers are not derailing from the expected, we ensured that the ministry clients were trained to differentiate between TB and COVID-19 symptoms, so that the provider knocks out the possibility of them being a COVID-19 suspect case. For example, the ministry clients were trained to respond in the negative to questions such as if they had a loss of taste or smell. Finally, the security situation made it a challenge to ensure the safety of some of the ministry clients in field, especially in the northern part of Nigeria, that is Kano. Data collection, also occurred during the fasting period, that's the Ramadan period, and most facilities in the north were more active after the day's fast, which was always in the evening. Hence, we had to ensure that vehicles drop off the ministry clients at a safe distance to the facility, as well as ensuring that they were not alone at all times to guarantee their safety. So I would like to pass it over to Lauren, and thank you all for listening.
Thank you, Mariose. So for the rest of this presentation, I'll present the results from our phase 2 analysis. And the main reason that we implemented a second phase of the mystery client survey was really to kind of understand whether the measures that Bola discussed previously in response to phase 1 were showing any signs of impact in the field. And then again, also to understand whether COVID was seemingly having an impact on how clinicians were interacting with TB patients. So I'll present the results by scenarios, starting with case 1, which was a scenario that that examined provider response to patients presenting with textbook symptoms of pulmonary TB, so chronic cough and fever. For case 1, I'll present the results for just SHOPS Plus clinical providers. We didn't implement case 1 in the second phase of the survey in public facilities due to resource limitations. Next slide, please. So there were 3 criteria that providers needed to meet to be considered to have correctly managed the mystery client for case 1. And as you can see in the dotted box at the bottom of the graph, less than half of the clinical providers across Lagos and Kano states where we implemented this survey were considered to have correctly managed the mystery client. Things look better, however, if you examine the results for the individual case criteria, which are shown above the dotted line box. So almost 2/3 of providers met the screening criteria, and almost all the providers avoided dispensing unnecessary or inappropriate drugs. The criteria that was the most difficult to meet in this scenario was that which was related to sputum sampling. So as you can see, just over half of the providers initiated a diagnostic at 53%. If you disaggregate the results by state, we found that providers in Lagos significantly outperformed providers from Kano in phase 2. Next slide. To understand whether phase 2 results were significantly different from what we observed in phase 1, we ran a series of fixed effects logistic regression models for overall correct management, as well as each of the individual case criteria to understand how they were doing on each of those different elements. We controlled for variables that mystery clients could observe and set the state and provider type as fixed. Overall, there were no statistically significant differences between phase 1 and phase 2. Mystery clients who interacted with just nurses in comparison to doctors were less likely to have been managed correctly. However, no other variables were significant in correct management. For the individual case criteria regressions, we found that there was no significant difference in the proportion of providers who met criteria for minimal screening or who initiated, referred for, or recommended a TB diagnostic. There was a significant improvement in the proportion of providers who refrained from dispensing inappropriate or unnecessary drugs or other antibiotics. And this is important because, as Bola explained previously, private providers in phase 1 lagged public providers in refraining from dispensing inappropriate or unnecessary drugs. So that improvement is notable. Next slide. Now we'll move on to looking at the phase 2 results for case 2, which was the confirmed patient case. We'll walk through the results the same way that I did for case 1, but this time we'll examine results for both SHOPS Plus private facilities as well as public DOTS facilities. So for this scenario, there were 5 criteria that providers needed to meet to be considered to have correctly managed the mystery client. As you can see in the dotted line box at the bottom of the graph, less than a third of providers in public dots and Shops Plus facilities, so public dots are in navy, Shops Plus are in teal, met all 5 criteria. However, by looking at the criteria individually, we can see that most providers were able to confirm the patient's diagnosis, avoid prescribing something other than TB medications, and make a plan with the patient to initiate treatment. Providers did the least well in terms of counseling that they provided to the patient and having a discussion with the patient about having and identifying a treatment supporter. There was no significant differences in how Shops Plus and public dots facilities managed patients in phase 2. So this continues to be a good pattern. Next slide. So now for the regression results for this case, compared to the results from phase 2, our regression models indicate that there is a significant positive difference between phase 1 and phase 2 for both Shops Plus and public dots facilities. There were no variables or covariates associated with better results than others. The improvement between phase 1 and phase 2 seems to be driven by significant improvement in the proportion of providers who confirmed the diagnosis with the patient and provided a basic explanation of TB. There were no significant improvements on other criteria, including discussion of treatment supporters, so that continues to be a lag area, and initiating TB treatment itself. That remained largely stable. Next slide. Before we talk about what we think these results mean for us, I want to remind you of a few study limitations. First, a key limitation of the mystery client survey design is that it limits observations to a single interaction at a single point in time. So it can't, for example, comment on providers' subsequent interaction and rapport building with TB patients over time. And this is important because we know TB treatment lasts for a long time and that rapport is important, but we're not able to comment on that. Second, mystery clients interacted with whoever was on duty at the time of their visit. So not everybody with whom the mystery clients interacted were directly trained or coached by Shops Plus. And the mystery clients did not necessarily interact with the same person in phase 1 as they did in phase 2. This was in part an intentional decision by the study team because Shops Plus intended that any training it provided at the beginning of the program would be diffused beyond those that were initially trained by ongoing program-provided supportive supervision and on-the-spot training and other resources that were provided directly to facilities. Third, in our regressions, we could only control for provider characteristics that were observable during interactions. Other factors such as experience level, previous formal training, attitudes or beliefs about TB were not obtainable, and so may have had a factor in the interactions, but we couldn't detect it. Finally, although I don't think there was evidence that supports that COVID-19 has directly impacted how TB service providers interacted with mystery clients, other than the fact that they were wearing PPE and perhaps maintaining some level of social distancing, I think it's still a possibility that other unobservable COVID-19 factors were at play, but we weren't able to detect those. And in fact, in any of our interactions in phase 2, COVID-19 never really came up. Very, very, very few mystery clients were actually asked about COVID-19 exposures, or it came up at all in any of the counseling. So now I'm going to hand things back off to Bola, who will lead a discussion about what we think these results mean for Nigeria and the rest of the world going forward. Thanks.
Thank you, Lauren. So to start off the discussion, we'll take off right from where Lauren stopped about COVID-19. Next slide, please. So looking at the performance of Nigeria mystery client survey compared to other countries, you see Nigeria being right in the middle. Nigeria did well, not as good as countries like Kenya, who implemented the mystery clients in the public sector. But we did much better than countries like South Africa, China, India, and Kenya, who implemented the mystery client survey in both the public and the private sectors. Next slide. So talking about COVID-19, we had expected that COVID-19 would shake things up a bit for both the public and the private sector. So the results that show that things are relatively the same as before is actually a good thing. Nigeria is actually one of the few countries that actually increased TB notifications in spite of COVID-19. And the findings from this ministry client survey and the collaboration with McGill University actually supported what we found in our notification data in 2020. It's also a good finding that we have evidence now that the private providers, at least those in the Short Plus network, compare favorably with the public sector in terms of quality of care. It's a good finding that it stands out as evidence and as a motivation to engage more private providers to increase TB case detection in Nigeria. Also, the fact that there was a significant improvement in the proportion of providers that either prescribed or dispensed inappropriate antibiotics or other medications is a good finding. This we can actually trace to the fact that our job aids and the counseling guide we give to the providers actually gave reasons why this should not be done and gave tips on how providers can counsel patients on starting TB treatment instead they are found to have TB. It also shows that our providers have embraced the TB program and they are finally settled in to provide TB services in line with the national standards and the Nigerian strategic plan and treatment guidelines. We did not see a lot of improvement in moving patients towards diagnostics, either by collecting sputum or referring them for x-rays. And particularly for the bottleneck in sputum collection that persisted even in phase 2. One explanation could be the COVID-19 pandemic, which makes patients very sensitive to being tested or being asked to collect, to submit sputum samples for testing, and also makes providers shy away from doing this so that they will not discourage their patients from coming forth for care for whatever reason. So this could be one effect that COVID-19 did have on our providers' behavior and quality of care. Now, we also had hoped that for confirmed patients, our providers would do better in terms of counseling patients towards engaging a treatment supporter. But we did see increase in the proportion of providers that counsel patients on TB, on TB treatment, on other aspects of providing treatment, except for that singular criteria of counseling patients on how to engage a treatment supporter. This could be explained by the fact that clinicians in both the private and the public sector, because this find actually cuts across both sectors, they are more inclined to provide the clinical aspects of TB care and less inclined to fill other public health obligations in managing and controlling TB. So engaging treatment supporters is like sort of a public health aspect of TB service provision that providers may not be too keen to do. And so the implications for Nigeria are such that we need to find a more effective and impactful way of getting our providers to counsel patients, not only on TB treatment, but also on engaging treatment supporters. The counseling guide that we've developed has information on all aspects, and yet we saw improvements in some aspects, but not in engaging treatment supporters with patients. Next slide. So we came up with this discussion points for the country on like next step and the so what for Nigeria. The first is to take more action and be more proactive in addressing sputum collection bottlenecks that exist, and also to strengthen the providers' resolve on how to correctly differentiate those who have COVID symptoms from those who have TB. So there will be no hesitation to collect sputum samples from those who are TB presumptive. We also need to come up as a country, as previously mentioned, on more good methods to make our providers more capable of helping patients to engage treatment supporters. This finding is not peculiar to this study alone. There have been other desk reviews done in country that shows a similar pattern that showed us that our patients in many cases don't have treatment supporters. So the result from this ministry client survey, both phase 1 and phase 2, just supports that known facts that we already have as a country. And of course, we now have evidence to confidently move on with scaling up private sector engagement in Nigeria. We now have evidence that the quality of care in the private sector is comparable and in some instances better than the quality of care in the public sector. And that's another major implication for Nigeria. And these 3 points are going to be taken forward and engaging with the national program at the annual review meeting starting tomorrow in Kano, where we're going to have a panel discussion on the findings for this ministry client survey and other quality of care issues in the country starting from tomorrow. Next slide, please. And to round off the presentation, we'd like to acknowledge the very many people who made this survey a success. The Short Plus team in Nigeria and in the headquarters in Rockville in the US, and also our collaborators, the Polycon team that helped to implement the survey in Nigeria, and of course the McGill University, who collaborated with us to make even the phase 2 survey even richer with the COVID-19 impacts assessment, and of course the USAID team in Nigeria and in Washington, and the National TB Program, who made this possible and supported and cooperated with us every step of the way, and the state control programs in Lagos and Kano. Thank you everyone for joining us and for making this happen. Thank you.
Thank you so much to Bola and to all the presenters for a really terrific presentation. So we'd now like to invite Madhu Pai to give us a bit of a reflection. Madhu has really pioneered this whole area of work globally, and from the very beginning has been very generous with his time and his team's time on assisting specifically with Nigeria work. So Madhu, please.
Thank you, William, and thank you, colleagues. It's really wonderful to see not only the phase 1 results, which I've seen before, but also the phase 2 results, which are very interesting to see. So just a few quick thoughts about the methodology itself. By now, including Nigeria, we have used this method in 7 countries: India, Nigeria, Kenya, South Africa, Indonesia, Vietnam, and China. All using the tools that we had developed along with Jishnu Das and others at the World Bank initially. And it seems to me, based on the 7-country experience, the methodology is robust, it does work, and we are not seeing any crazy results across these 7 countries. So that kind of reassures me that the method itself is robust across settings. And as you may all know, we have a manual and a toolkit published in the open domain. So if anyone is interested in adapting the methodology, they are more than welcome to do so with or without our engagement. It's all free access. More recently, a few groups have tried to do some innovations around this method. For example, our team working with our colleagues in Indonesia is now doing a virtual SP for teleconsults. And virtual SPs, we are waiting to see what those results will look like, to see whether as digital health and telehealth increases, what an online consultation for TB might look like and what quality of care means in that setting. I myself don't know what a yardstick for judging an online consultation at this point should look like. The other thing that we are learning is that the methodology has limits. Some of the limitations are very nicely outlined in this presentation. I think the most important limitation in my mind is that this methodology works well in the front half of the cascade of care. What is done to people when they walk into a consultation? Are they tested or not? Are they counseled or not? Those things can be identified. What we are not able to do successfully with this methodology is go across the cascade of care all the way to adherence and treatment completion and so on and so forth. So I would say it offers an incomplete window into the entire patient continuum of care. We will need to come up with other methods, including cascade of care, digital adherence technologies to go all the way. And then as more and more people in TB are talking about post-TB lung disease and post-TB syndrome, that requires even longer term follow-up, which we are not able to account for in this method. I think the method works best when we have longitudinal follow-up data, as we saw in Nigeria, as we've done in India, because one point in time as a cross-sectional, there is only so much information. And I would love to see, as Nigeria has successfully shown, to do some quality improvement, make some changes, and then go back and see whether those changes have done what they were intended to do. So as part of a quality improvement program, this method, I think, has the best chance of succeeding rather than a one-off dipstick type of a survey. So across all 7 countries, it seems to me that about 30 to 40% of the interactions are quote unquote correctly managed in the private sector. In at least 3 settings, we are finding that public does better than private. That's India, that's South Africa, and that's Kenya. And I think the reason why public does better is that the public is very protocol oriented, and sputum testing comes in very quickly and very early. While, as we have seen, sputum testing is seriously underused in private sector across all 7 settings that have been looked at. I think the underusing of smears and sputum testing is one of the biggest bottlenecks in private sector TB care. Chest X-rays are much more welcomed in the private sector. And I think broad spectrum antibiotic use is extraordinarily high across all 7 settings. That's one very consistent finding, that private providers prefer to empirically manage first before they will test at all. And that seems to be a consistent issue that all of us have to face. Now, with intervention, at least in some settings, we have data that quality of care can increase and improve over time. So that's why I think it's important, as William pointed out early on, that we don't give up on the private sector after just one round. We have to intervene and see how the trend improves over time. Same for microbiological confirmation over time, same for treatment completion over time. If you look too early at a private sector intervention and you don't find it to be very impressive, I think if we give up, then we would have lost an important opportunity to stick with them over time. Behavior change is hard, as we are seeing, learning from this pandemic. So it's important to stick with them over a period of time, support them to do better, and show that they can perform as well as the public sector or even better in order to restore confidence in PPM projects and scale them up. In terms of my last comment for Nigeria, I would love to know if there's any increase or data on increase of private sector cost of care as a result of this pandemic. And is there any hint that private sector providers are now confusing COVID testing, COVID with TB, and then asking for COVID test first before testing for TB, or vice versa? It seems to me, from what Bola mentioned, COVID is not even coming up during these interactions in Nigeria. We are finding in Patna, hardly anyone is even talking about COVID right now. That may be because caseload in India has gone down. So this confusion between TB and COVID and the need for bidirectional screening is still a confusing issue for all of us in TB. There's a lot of interest, but I'm not sure the yield of bidirectional testing has been well studied. And it would be nice to see whether anybody is even asking for a COVID test at all in these settings, given what the situation is in terms of the COVID epidemiology in these countries. Thank you. Back to you, William.
Thank you so much, Madhu. Really, really helpful context. So we'll now move into Q&A, and maybe we can start with Madhu's questions about COVID, both the cost issue and the testing issue. Is there anyone from the Shops Plus team who can comment on those two issues? Paula, please.
Yeah, thank you, Dr. Pai. It's true that providers really shy away from talking about COVID. In one of the slides that Lauren presented, she actually showed that COVID came up very rarely in the interactions with the ministry clients. And that goes further to prove that providers just want to avoid the topic as much as they can. However, there have been isolated surveys done by TB implementers in country. So there was one that was done in a COVID isolation center, which used to be a major TB treatment center in Lagos, the mainland hospital, that showed a high positivity rate, high yield of TB among people who came to test for COVID. These were COVID suspects referred from different parts of the city and that presented in mainland hospital. And we took time to collect samples from them and test them for TB. And it was about a 16% yield of TB among this small group of people. That's about the only study that we have right now that categorically speaks to bidirectional screening.
I'll just add a few of our early learnings from the study that we've been working on with you, Dr. Pai. So the COVID impact study that we've been a part of, some of the early data from Nigeria show that maybe part of the reason that COVID in our mystery client study came up so infrequently is that a lot of the policymakers that we talked to, as well as some of the provider or the patients that are part of that study, both of those stakeholder groups remarked on some level of, well, there is quite a bit of stigma around COVID-19, as we know. And in some ways, the private sector has been able to almost kind of leverage that in their advantage. And so a lot of people go to the private sector specifically not wanting to engage with the COVID screening, being isolated, all of those things, because Nigeria has centralized their COVID response in the public sector. And so for that reason, you see a lot of people, or what the perception is you see people going to the private sector. And so what I would imagine is, since we know that a lot of providers tend to sometimes defer to what their clients' preferences are, because that gives them a comparative advantage over the public sector, is that they're not bringing up COVID because they don't want to isolate or alienate their clients. So that could be one reason. We don't know that for certain, but given those triangulating between these different data sources that we have, I'd say that's probably some factor. And then in terms of cost, I think there's still sort of ongoing analysis of that cost related data. Some of it is a little bit affected in our own network because of the way it's subsidized through USAID and through the national program. But the perception among providers and patients is that costs in general are going up, as they are in many countries around the world. So specifically with the cost of TB care, to the patient, I don't know from a facility to facility basis, but certainly costs in general are going up, which is causing some access issues across the board.
Great, thank you. So the second question I'd like to move on to is, what do you believe were the factors that contributed to there being little difference between phase 1 and phase 2 results, despite COVID? So kind of staying with the COVID theme.
Yes, thank you, William. We actually put in some measures, both generally to address the gaps we saw in phase 1 and also specifically for COVID-19. So in terms of the weakest points that we found in phase 1, that of collecting samples from patients for testing, and that of counseling patients generally about TB and about engaging treatment supporters, we strengthened our sputum transportation system to ensure that we are more efficient and effective, and providers have more confidence in the system. But what we noticed around the time we had phase 1 survey was we had inefficiencies in the system, we had delays in picking up samples, and sometimes long turnaround time for test results to come back. And we felt that could have demotivated providers from moving ahead to collect samples from presumptives. So we strengthened that, and we had hoped that this would bring about a remarkable improvement. And then COVID happened. And then all the issues that Lauren just spoke about came up about, not only to isolate patients. Some private providers did not even want to screen anymore. They just want to attend to patients and not mention cough or sputum. But we also put in some measures, our COVID adaptation mechanisms, where we had a lot of virtual seminars on how to differentiate COVID-19 suspects from presumptive patients, where we had talks about infection control. We supplied infection prevention and control materials we got approval from USAID to actually procure and supply to the providers so that they could keep working in the front lines. And we also told them about x-rays, how x-ray features can even differentiate those who have COVID from those who have TB, and lots of other things that we put in place to ensure that providers kept providing services in spite of COVID-19. And so I think that's actually helped a lot to reduce the impact COVID-19 could have had on the quality of TB services in the private sector.
Great, thanks, Bola. Maria, so I had a question for you. I found the adaptations that you had to make for practical reasons for the survey particularly interesting. I know this methodology is very much focused on quantitative results, and that's what was presented. I'm wondering if more informally you kind of came across any interesting qualitative findings that you then kind of passed to the Shops Plus team that may be interesting for the audience or that led to interesting adaptations in the programming?
Yeah, so basically, although we collected, like you mentioned, quantitative data, but we also had room for some qualitative interaction where the mystery clients had the opportunity to put verbatim some of the things they could remember during their interaction with some of the providers. And because we were monitoring this on a daily basis, as well as interacting with the mystery clients, we were using those to come up with, like I mentioned earlier, daily strategies, mitigation strategies to cope some of these things and make the next visit much better and with the lesser potential detection rate. For example, we've had cases where, some of the mystery clients would mention that the nurse they met on duty, for example, in phase 2, one just came up, vividly mentioned that I think these people are back. That's in quotes the mystery clients, and we weren't certain if she meant those that came during phase 1 or some of these other cases. But we had to take that seriously and had to come up with such strategy to ensure that what was meant was not what we thought. So some of those things were also in the results. As we send it in and discuss with the shop loss team, we collaborated together to thinking out some of these things, because it is not just about the quantitative findings. So it's about what their experiences were in the field, because it was so very dynamic. And during data collection, so many things were just coming up on a daily basis, and we had to continue thinking through it every time it came up. So yes, it was not straight out of textbook thinking. It was also what we had to think on a daily basis based on the localization of the thoughts around how providers are thinking or interacting with these mystery clients on the go.
Great, thank you. And I think maybe just one last question for maybe Lauren can start. Madhu, I think, raised an interesting and very clear point on the part of the cascade that these kind of surveys can really address. Do you have any further reflections on where this kind of survey fits into an overall M&E and research agenda for private provider engagement for TB? Can you talk a little bit more about sort of the broader picture of what is needed on the research and M&E side, and where this kind of specific study kind of fits into that broader perspective?
Yeah, I mean, I hope what's clear by now, Madhu knows this well, is that mystery client surveys for TB are particularly tricky to implement. At CHOPS, we've used mystery clients for many, many years to gauge how, let's say, training for drug sellers, how that translates to real world action. But because there's so much kind of intense interaction between clients and providers in TB, it is a difficult study to pull off for all the reasons that Mariose said. So I think you have to use this method sort of judiciously. And where I think it was important for us, especially in phase 1, as we were implementing this relatively complex PPM model in Nigeria for the first time, is it really kind of helped us understand, both show that, hey, with support, you can get private providers basically providing TB services at the same status quo quality as the public sector. And I think there's always a bias around private sector being categorically less good quality than public. And I think what we were able to show is with intervention and with this sort of unbiased methodology, you're able to really have a program that kind of contributes to overall detection. Our larger phase 1 study actually included mystery clients in multiple different cadres, and I think it was really useful for that too, establishing that you can have not only good quality screening in clinical providers, but also non-clinical providers as well. So I think it was really helpful for us to prove our point of concept and sort of show that the network was worth pushing on with for many reasons. I think to do this regularly would be kind of cost prohibitive, and because it only gives you that first interaction or that first picture of what the interaction looks like, it's not it isn't useful for really understanding the full cascade. So I think I would use it probably as you're implementing new PPM models around the world or new and different settings, and maybe doing it a couple times to sort of understand how things are changing over time. But to be honest, to actually do this on a regular basis, I think would be very difficult for everybody. It may kill people like Mariose, who worked really, really, really hard to get this going under incredibly difficult circumstances. So it isn't an easy undertaking, but I think it is important, provides us really good data that we can say, okay, this is a good place to start. Now, where do we go? Bola, I don't know if you have any other thoughts. Oh, you're muted.
Yeah, sorry. I completely agree with you that it's actually necessary to assess quality of care whenever we're introducing new PPM models in different parts of the world. So like you said, it is necessary, but should be restricted to only when it is really necessary. Thank you.
Great. Well, thank you to the whole panel and to the whole team for a fantastic study. We'd like to close with some comments from Guy Stallworthy from the Gates Foundation. So Guy, over to you.
Thanks very much, Madhu, and to the whole SHOPS, William and Madhu and the whole SHOPS team for that very interesting and important work. Private provider engagement is clearly going much better in Nigeria these days, and this kind of work, I think, as William said, just enriches our understanding so much compared to just mere notifications. It does show how hard it is to change behavior on sputum and prescribing practices. The countries that have been really doing well in this area have stuck with it for more than 15 years. I'm thinking countries like Pakistan and Myanmar. And I think I hope everybody on the call in Nigeria understands that this is not something you just do for a short-term project. This has got to be there for the long term in order to change these behaviors. I actually would disagree totally with the last comments about how this methodology should be used. I would encourage, and I know in Nigeria there's some well-resourced, very professionally run large-scale interventions. I think it's possible, I know from my own personal experience, it's possible to incorporate mystery clients into routine M&E within a well-resourced program with an M&E function. And it's not easy, of course, there are issues, but those issues can be overcome over time. And I think the richness of this data to test whether you are having an impact, whether your interventions are improving things, and how long it's taking is well worth the effort in terms of managing a good program over time. So those are my only comments. Congratulations to everybody for doing this work. I just would encourage everybody not to be too daunted by what you're hearing. It's difficult, but it's totally feasible, and the quality of the data is very well worth it on a routine basis. Back to you, William.
Great. Well, thank you again to the SHOPS Plus team for a fantastic presentation, and more importantly for the incredibly hard work and excellent data that came out of this. And again, really great to see quality being front and center in the TB world. So thanks to everyone, and we will see you next time. Bye for now.